Okay, hello everyone, and thanks for joining our annual ICD-10-CM 2023 Updates and Regulatory Readiness. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode, but if you have any questions during the webinar, just type them into the questions section. And at the end of the webinar, we'll get to as many questions as we can during our Q&A section. And if for any reason yours is not answered, we'll respond to you after the webinar. We like to keep things interactive, so throughout the webinar, we will be launching poll questions. Today, we have two presenters, June Braunert, Senior Director of Global Clinical Services, and Dr. Julie Glasgow, Clinical Terminologist. And I wanted to give a special thanks to Teresa Rehanick for her slide curation. As mentioned before, if you have any questions or comments while our presenters are speaking, type them into the questions section. And with all of this being said, I'm going to pass it over to June Braunert.
Great, thank you, Jordan, and welcome everyone. So any disruption of the revenue cycle is highly impactful. Preventing the submission of outdated or wrong codes resulting in denied or delayed reimbursement is key. Preparing your organization for the new ICD-10-CM codes supports an uninterrupted revenue cycle. And by using clear, up-to-date terms, especially when clinician interface terminology, supports the appropriate code submissions as providers capture their clinical intent for translation into codes. So let's get started exploring new terminology and code changes. Here are our objectives for today's session. We are going to review additions and revisions for the various body systems for ICD-10-CM, as well as highlight additions to the official coding guidelines, while looking at changes in index and tabular, as well as additional new social determinants of health codes, and review modifier changes to ICD-10-CM. So we'll start our review with the new codes effective April 1st. April 1st this year was the second regular update of ICD-10-CM. There were 3 new codes related to immunization status. The guidelines were also updated to provide instructions related to the use of these codes. Now let's look at the changes for October 1st, starting with the numbers. There are over 1,000 code additions, 287 deletions, with 28 code title revisions occurring for fiscal year 2023. As you can see by the graph, the system continues to grow year over year. So let's look at the changes for October 1st. Vulvovaginal candidiasis, commonly known as vaginal yeast infection, is estimated to occur at least once in 75% of women. While most of these infections are uncomplicated with mild to moderate symptoms, there are times when clinically distinct complicated infections occur. Most prominently, complicated infections refer to recurrent vulvovaginal candidiasis, which is defined as 3 to 4 or more episodes of symptomatic infection within 1 year. 2 new codes, as shown here, were created to identify complicated infections. Next, looking at neoplasm changes, code title descriptions were revised to address the omission of elsewhere and not elsewhere classified for the codes shown here. Other changes include index additions and revisions. The additions provide clarity related to myelodysplastic and myeloproliferative disease. There is now a specific entry disease, myeloproliferative. It is interesting to note that if the myeloproliferative disease is stated as not classified or unclassifiable, use code C94.6. Osteochondromatosis was previously classified to D48.0, which is a neoplasm of uncertain behavior and has been reclassified to benign neoplasm of bone, D16.9. A new guideline related to secondary malignant neoplasm of lymphoid tissue for when the tissue metastasized beyond the lymph node is added. The final character of 9 should be assigned instead of a secondary neoplasm of affected solid organ. Hemolytic uremic syndrome was revised, as we will see on the next slide. Hemolytic uremic syndrome is a rare disorder causing thrombotic microangiopathy that can be described by the presence of hemolytic anemia, thrombocytopenia, and acute kidney injury. Typical and atypical are the two main categories of HUS. Typical hemolytic uremic syndrome is due to Shiga toxin-producing E. coli, or STEC, and most commonly appears in children under 5. Acute kidney injury occurs in more than 70% of the patients. Typical HUS is treated with supportive care to address the anemia, acute kidney injury, and other conditions. And while most patients recover from the AKI, some do go on to develop chronic kidney disease and other ischemic organ injuries from the microthrombi. Typical HUS is now classified to D59.31. Atypical HUS occurs in both adults and children, but represents approximately 10% of all hemolytic uremic syndromes. Many different etiologies can cause atypical HUS, which include gene mutations. Other causes can include non-STEC infections, adverse drug effects, and conditions such as COVID, bone marrow transplant, malignancy, or systemic lupus erythematosus. Treatment is based upon the causing condition, and codes for the atypical HUS due to a genetic cause are captured with D59.32, while atypical hemolytic uremic syndrome due to other conditions such as COVID are classified to D59.39. Two coding guidelines have been updated for HUS-related HIV and sepsis conditions. As one can see on the slide, historically, when a patient with HIV is admitted for an HIV-related condition, the principal diagnosis is B20, followed by the HIV-related condition codes. Now there is an exception. If the patient is admitted for hemolytic uremic syndrome associated with HIV, code D5931 is assigned first, followed by B20. The same admission guideline is true for sepsis. Code first the HUS, followed by the underlying systemic infection. Turning our attention to von Willebrand's disease. Von Willebrand's disease is the most common inherited bleeding disorder in which the blood does not clot properly, with wide variability in clinical phenotype. According to the Centers for Disease Control and Prevention, about 3.2 million, or about 1 in every 100 people in the United States, have the disease. New codes are available to identify the type of the disease as shown on the slide. Type 1 von Willebrand's disease is characterized by decreased levels of von Willebrand factor, or VWF. The VWF that is made is functionally normal, however, lower circulating levels lead to an increased risk of bleeding. All forms of type 2 von Willebrand's disease are characterized by functional defects in the VWF, with subtyping based upon the specific functional defect. There are new codes at the subcategory D68.02 to identify the various type 2 subtypes. Type 3 von Willebrand's disease is a qualitative form of VWD with near complete absence of circulating VWF, and this is the most severe subtype. Acquired von Willebrand's disease syndrome is a deficiency in the amount or function of VWF. The underlying cause is acquired rather than inherited. An example is the shearing and degradation of VWF across stenotic heart valves or related to mechanical circulatory support circuits like left ventricular assist device, or ECMO. D6809 classifies other von Willebrand diseases such as platelet-type von Willebrand disease. The condition is due to a functional defect in the platelet receptors for von Willebrand factor. Another change related to von Willebrand disease is the inclusion note at R71.1 for low von Willebrand factor. A related index change has been incorporated into the classification. Other changes to blood disorders are seen on the next slide. Heparin-induced thrombocytopenia, or HIT, is a decrease in platelet count that occurs during or shortly after exposure to heparin. This is a common problem as heparin is used for treating and preventing blood clots. There are various types of HIT. D75.82 subcategory is revised to include new codes for the different types of HIT. Type 1 HIT is known as non-immune HIT. It is a non-immunological response to heparin treatment mediated by interaction between heparin and circulating platelets, causing platelet clumping or sequestration. It is characterized by mild and transient thrombocytopenia that returns to normal after heparin is withdrawn. Type 2 heparin-induced thrombocytopenia is an immune antibody-mediated reaction that causes thrombocytopenia about 5-10 days after starting heparin. The patient may also have a hypercoagulable state. The immune complexes activate platelets that in turn promote excessive thrombin generation, often resulting in deep vein thrombosis or pulmonary embolism. There are also atypical presentations of HIT, one known as autoimmune heparin-induced thrombocytopenia syndrome. The platelet count can continue to decrease even after heparin is stopped. Patients may display unusual features such as severe and persistent thrombocytopenia and even DIC, disseminated intravascular coagulation. D7584, other platelet activating anti-PF4 disorders, was also introduced to capture other types of platelet disorders that do not involve exposure to heparin. APDS is primary immune regulatory disorder that is defined as combined immunodeficiency and now has a new code D8182. Next, we'll look at endocrine disorders. Short stature is defined as having a height and length that is 2 standard deviation scores away from the mean height and length of the age group. As short stature has a variety of causes, identifying the underlying cause is the first step. The code E34.3 was further expanded to include new codes identifying the different causes of short stature. The new codes more closely align with the current Pediatric Endocrine Society recommendations for diagnosis. Constitutional short stature or constitutional growth delay describes patients with an unknown cause of short stature. This diagnosis depends on ruling out other causes of short stature. And subcategory E34.32 contains 4 new codes identifying various genetic causes of short stature as seen on the slide. And on the next slide, we will look at acidosis changes. Chronic metabolic acidosis is both a serious complication and an underlying cause of chronic kidney disease progression. As kidney function deteriorates, patients cannot secrete adequate amounts of acid. The resulting acid-base imbalance leads to a reduction in serum bicarbonate. It is a clinically distinct disorder from acute metabolic acidosis, which either results from hypoperfusion, alterations in glucose metabolism, or less commonly from ingestion of toxic substances. Acute metabolic acidosis is typically associated with conditions that result in hospitalizations, and treatment is primarily aimed at correcting the underlying etiology. The codes now separately classify acute versus chronic metabolic acidosis. We'll now turn our attention to behavioral health changes. Dementia, which is also known as major neurocognitive disorder, was expanded to capture the stage of severity and the associated behavioral and physiological symptoms of dementia. These clinical elements are major factors in patient treatment and overall management. Dementia moves through 3 stages of cognitive impairment or neurobehavioral changes. They are mild, moderate, and severe. The severity stages center around changes in an individual's daily function, and they are defined as follows. Mild dementia is clearly evident functional impact on daily life, affecting mainly instrumental activities, and no longer fully independent and requires occasional assistance with daily life activities. Moderate dementia is extensive functional impact on daily life with impairment in basic activities, no longer independent and requires frequent assistance with daily life activities. Severe dementia a clinical interview may not be possible, and complete dependency due to severe functional impact on daily life with impairment in basic activities, including basic care. Behavioral and psychological symptoms of dementia, or BPSD, are the existing code structures of classifying dementia without and with behavioral disturbances is a less specific way to represent the key associated disorders. And key associated disorders represent significant clinical problems and many times are the reason care is sought for dementia patients. Providers typically treat the associated disorders, such as prescribing medication for delusions occurring within the diagnosis of dementia. BPSD can generally be grouped into three main categories: behavioral disturbances, psychotic disorders, and mood affective disorders. Coding changes reflect these three main categories along with agitation and anxiety specifically. This slide illustrates the new clinical elements being captured with the codes. The axis of classification starts with the stage of severity, and in this instance, the severity is unspecified. The next axis of classification is the BPSD, and note the behavioral disturbance, including agitation, along with psychotic and mood disturbances. The next slide reflects different stages of severity. And as you can see, here's another example of the stages of severity along with the behavioral and psychological symptom distinctions. There is also a use additional code if applicable to identify wandering in dementia Z91.83 at the other behavioral disturbance codes. A new guideline has been added regarding the assignment of the new dementia codes. Severity must be documented by the provider unless there is a classification guidance that identifies severity. When the documentation does not indicate the severity of dementia, then use the unspecified severity codes. Another interesting call-out is that if a patient is admitted to an inpatient setting with mild dementia that progresses to moderate dementia, the coder will only assign a code for the dementia with the highest severity, and in this case, that is the moderate. And next, we're going to look at neurocognitive disorder changes. Mild cognitive disorder, also known as mild cognitive impairment, often precedes dementia. And mild neurocognitive disorder is characterized by cognitive defects that exceed those expected for a patient's particular age, but do not reach the level of clinical dementia. And on the next slide, we will see two new codes created to classify mild neurocognitive disorder. The two new codes were added at F06.7 to capture mild neurocognitive disorder associated with known physiological conditions. There is a coding note instruction to code first the underlying physiological condition in order to allow for the specification of the underlying pathological condition. And next, we will review the title revisions necessary to support these changes. Due to terminology changes, code titles needed revised to reflect the distinction between mild neurocognitive disorders and dementia or major neurocognitive disorders. Here you can see the new descriptions as compared to the old code titles for these existing codes. For G3109, the title was changed from Other Frontotemporal Dementia to Other Frontotemporal Neurocognitive Disorder. G31.83 was changed from Dementia with Lewy bodies to Neurocognitive Disorder with Lewy bodies. These changes allow these two codes to be used with the F06.7 codes for mild neurocognitive, as well as the codes in F02 for associated dementia. The title change for G3184 revised the code from mild cognitive impairment so stated to mild cognitive impairment of uncertain or unknown etiology. When the mild neurocognitive impairment is not due to a disorder such as Alzheimer's, traumatic brain injury, or the cause is yet known, this code is to be assigned. This example illustrates the coding differences between mild neurocognitive disease or mild dementia with Alzheimer's. And as you can see from the tabular, if the patient has mild neurocognitive disorder and Alzheimer's disease that has not yet progressed to dementia, the codes assigned would be G039 and F06.70. Other behavioral health changes involve substance use disorder. A new code for alcohol has been added at F10.90. The index for use alcohol was changed to F10.90 from Z72.89. Other problems related to lifestyle. Keep in mind that the coding guidelines from the mental health chapter 1C5B3 psychoactive substance use directs one to only assign a code for unspecified psychoactive substance use that is associated with a substance-related disorder or medical condition with the relationship documented by the provider. New codes were also incorporated for the unspecified use state of the alcohol or substance in remission. These codes are to capture those cases that the patient is known to have been previously diagnosed with a substance use disorder and the pattern of substance use meets the criteria for remission status, but the severity of the substance use before achieving remission status is not known. Some index changes related to alcohol identify that alcoholic delirium now defaults to F10.921, which is alcohol use unspecified with delirium instead of alcohol dependence with delirium. Also, new subterms have been added to capture the withdrawal state related to alcohol that the patient is in a dependent, moderate, or use disorder pattern or is not. However, the default for alcohol withdrawal is the dependence code. The last two items to draw your attention to are related to schizophrenia and prolonged grief disorder. A new code for prolonged grief disorder. This is a disorder of intense, prolonged symptoms of grief coupled with clinically significant functional impairment that persists for over a year after a loss. 1 out of 10 bereaved adults following a nonviolent loss is at risk for developing prolonged grief disorder. Also, chronic undifferentiated schizophrenia has been reclassified in the index from F20.5 residual schizophrenia to F20.9 unspecified schizophrenia. And now it's time for our first poll question. Jordan, will you please review?
Yeah, so the discharge summary is an 85-year-old man admitted for moderate vascular dementia with depression. His dementia progresses to severe over the course of the stay. His discharge diagnosis is severe vascular dementia and depression. So I'm going to launch the poll question and you guess the code. So is it F01.C3 and F01B3, F01.C0 and F32.A, F06.71 and F32.A, or F01.C3? I'll give it a few seconds and then I'll close the poll. All right. Almost. Okay, I'm going to go ahead and close it. And it looks like B was the winner for right now. Is that correct, June?
Well, and actually this is a poll question, and then the answer is really D, because the depression is considered a mood disturbance, and there's not a note to use an additional code, and so that is, so you do not need to assign a separate code for depression, as it is covered under the code descriptor with the mood disturbance, and there's not an additional code at this time. So we'll continue with our review, and we're going to look at limb-girdle muscular dystrophies. As there are 5 common types of muscular dystrophy, one of which is limb-girdle, or limb-girdle muscular dystrophy, LGMD, has previously been included in code G7109. In October, LGMD will be classified separately to their own unique codes. The LGMD is a group of genetically inherited conditions that primarily affect proximal skeletal muscle, leading to loss of muscle fiber and progressive muscle weakness. There are currently 34 subtypes of LGMD with different genetic causes, and as you can see from the code descriptors, the new codes classify the different subtypes. Many inclusion notes and extensive new indexing assist one with identifying the correct code for specific subtypes. And changes to the neurological conditions are seen on this next slide. So these include a new code for postural orthostatic tachycardia syndrome, or also known as POTS. POTS is a chronic autonomic nervous system disorder. Infectious agents are one of the most common triggers for the onset of POTS. The National Academy of Medicine, formerly the Institute of Medicine, published an extensive review of myalgic encephalomyelitis, or ME, and chronic fatigue syndrome, or CFS, providing new diagnostic criteria which has been adopted by the CDC and others. ME/CFS is a serious, chronic, complex, and multi-system disease characterized by post-exertional malaise, which can last for days, weeks, or even months. ME/CFS often follows a viral infection, but not always. The code G93.3 was expanded to align with the new criteria. Also note that chronic fatigue syndrome has been reclassified to G93.32 from R53.82, which is for chronic fatigue. Systemic exertion intolerance disease is now also indexed to G93.32. The circulatory system is the next section to review. And here, refractory anemia is conventionally defined as a chronic condition characterized by angina in the setting of coronary artery disease, which cannot be controlled by a combination of optimal medical therapy, angioplasty, or bypass surgery, and where reversible myocardial ischemia has been clinically established to be the cause of the symptoms. Refractory angina is common not only in patients who are not good candidates for revascularization, but also in patients following successful revascularization. Persistence or reoccurrence of angina after PCI, or percutaneous coronary intervention, or CABG surgery is well recognized and may affect 20 to 40% of patients during short and medium-term situations. And aortic aneurysm codes in I-71 were expanded as well. An aortic dissection is a tear in the aorta that occurs between the innermost layer and the media, the middle layer. Expansion of this tear can block critical vessels branching from the aorta, leading to ischemia of the affected organ or extremity. A dissection that is restricted to the aortic arch may be treated in multiple different ways, depending on the exact location of the tear and the presentation of the patient. A focal dissection of the aortic arch could be treated with endovascular stent placement, which has a very different patient risk exposure compared to surgical reconstruction of the ascending aorta. New codes were created for dissections of the ascending aorta, aortic arch, and descending aorta, as seen here. There are also new codes for rupture and non-rupture of the ascending aorta, aortic arch, and descending aorta, as shown on this slide. And new codes for I-71.3 and I-71.4 following a similar pattern as I-71.1 and I-71.2. The new codes classify more specific locations of abdominal aortic aneurysm, both ruptured and without rupture. And so, for example, I-71.33, infrarenal abdominal aortic aneurysm ruptured is a new code. This slide shows the last of the changes to I-71 category and follows the same pattern to identify more specific locations for a thoracoabdominal aortic aneurysm. And the next slide shows the last of the cardiovascular changes we will discuss. Malignant pericardial effusion is a complication of a neoplastic disease. The most common etiologies of malignant disease of the pericardium include cancers of the lung and breast, while a number of other cancers may also produce malignant neoplasms, including malignant melanoma and leukemia or lymphoma. A new code was created to classify the condition. Other cardiovascular code changes are shown here, including 2 new codes and a revised index entry for subsequent transmural myocardial infarction. Next, we will review changes for respiratory and digestive. A new code for transfusion-associated dyspnea was established. Transfusion-associated dyspnea is defined as acute respiratory distress occurring within 24 hours of cessation of a transfusion, and the following are not applicable: an allergic reaction, transfusion-associated circulatory overload, or transfusion-related acute lung injury. J95.87 is not to be used with transfusion-associated circulatory overload or transfusion-related acute lung injury. K76.82, hepatic encephalopathy, is a new code. Hepatic encephalopathy involves altered consciousness and behavior due to the loss of brain function occurring from the liver being unable to remove the toxins. Other digestive system changes include a revised title and index updates for appendicitis with gangrene, as shown on the slide. We will turn our attention to the musculoskeletal system. There are 2 main muscle groups in the back that are subject to primary muscle wasting and atrophy. This includes the paraspinal muscle and the multifidus muscle. The multifidus muscle, which is the dark red muscle on the image, runs the entire length of the vertebral column and on both sides of the vertebral column. The paraspinal muscles are part of the deep muscular of the back, and they run from the cranium all the way to the pelvis. In muscle wasting and atrophy, there is a degeneration resulting in decreased muscle size. There are newer treatment options to address muscle wasting of the back, including implantable neurostimulation. 4 new codes were created to identify cervical, thoracic, lumbosacral, and unspecified sites. Note, a unique code for lumbar was not created. In some patients with a lumbar disc herniation, there may also be rupture of the annulus fibrosus, which occurred during the herniation event. The annular defect increases the chance of the remaining disc to reherniate. Patients with large post-surgical annular defects are at a greater risk. The International Society for Advancement of Spine Surgery indicated in the proposal that they consider a small defect to be less than 6 millimeters wide and less than 4 millimeters high. Large defects are greater than or equal to 6 millimeters wide and greater than 4 millimeters high. When coding for an intervertebral annulus fibrosis defect, assign the appropriate intervertebral disc herniation code first, and then a code for the defect. Slipped capital femoral epiphysis, or SCFE, is a failure through the growth plate that results in slippage of the proximal femoral epiphysis. Slips can be both stable and unstable. To capture both the severity and stability of the slippage, new codes have been added, but let's start with the review of the title revisions. For the first group of codes listed on the screen, these existing codes have been revised to include stable in the title. A stable SCFE causes some stiffness or pain and maybe a limp, but this often comes and goes, and there's good prognosis for functional recovery. New codes were added to capture an unstable slip. An unstable SCFE is a more severe slip that happens suddenly and can cause tissue necrosis in the head of the femur. There were also new codes to identify when the stability of the slip is not documented, as well as when bilateral hips are involved. And continuing on with the musculoskeletal changes, we'll look at fractures associated with CPR. The performance of CPR carries a known risk for rib fractures, especially in elderly patients or people with osteoporosis. Rib fractures may be unavoidable in order to provide sufficient external pressures to support perfusions of the brain and other organs. New codes have been added in the musculoskeletal procedure complication codes to identify these specific injuries. Do not separately assign a code for the injury from Chapter 19. See Coding Guideline 1C 19B3 for further details. And lastly, for the musculoskeletal, we will review indexing changes. Derangement of specific joint sites of the ankle, elbow, and hip were updated. This reclassification changes the code from M24.9 unspecified joint derangement to M24.1 other articular cartilage disorders. Of note, shoulder was not updated in these changes. IMO has requested the committee to review to update the shoulder entry for consistency. Degenerative scoliosis was reclassified to other secondary scoliosis instead of other forms of scoliosis, and osteoarthritis has several new index entries to clearly identify where post-traumatic primary and secondary osteoarthritis of the joint site is coded to. Now let's look at genitourinary changes. Starting with endometriosis. Endometriosis is a condition in which tissue similar to the endometrium grows outside of the uterus. Typically, endometriosis involves ovaries, fallopian tubes, and the tissue lining the pelvis. Over 130 new codes have been added at N80 to classify laterality, further specify location, and identify the depth of invasion. Depth of invasion is classified either as superficial or deep. Superficial endometriosis is defined as ectopic growth of endometrial-like tissue that extends 5 millimeters or less below the peritoneal surface. Lesions can vary in numbers, singular, or in multiple locations. And while deep infiltrating endometriosis is defined as ectopic growth of endometrial-like tissue that extends greater than 5 millimeters below the peritoneal surface. Again, these lesions can vary in number, singular or multiple, and these lesions are commonly associated with deep fibrosis and adhesions. Contrast-induced nephropathy is the third leading cause of hospital-acquired kidney injury. About 2% of the people that receive dyes can develop contrast-induced nephropathy, but it carries a higher risk for people with diabetes, heart and blood disorders, and chronic kidney disease. A unique code was created to identify contrast-induced nephropathy. There is also an excludes to note at this code, which allows for the assignment of acute kidney failure N17. Fournier's disease is a necrotine fasciitis of the perineum. It develops abruptly with severe pain and may rapidly spread to the anterior abdominal wall and gluteal muscles. Previously, the code for female Fournier's disease was represented with N7589, other specified inflammation of vagina and vulva. This new code will accurately reflect Fournier's disease in females. Finally, a new code for isthmocele has been implemented for the defect in the myometrium from a cesarean section in a non-pregnant patient. This is essentially a dehiscence at the site of a previous C-section, and in a non-pregnant patient, an isthmocele may cause pelvic pain, abnormal uterine bleeding, secondary infertility, spotting, and other symptoms. The indexing for isthmocele is interesting to arrive at this code. The slide shows the only two entries currently available to arrive at N85.A. Coders will have to review the tabular to ensure proper classification of patients that are not pregnant. And next, the maternal care code changes are related to birth defects. So in the US, 3% of all babies are born with a birth defect, which is about 120,000 every year. Birth defects are leading cause of infant deaths, and the new codes which have been added to maternal care for suspected fetal malformation or anomaly will help to assess the quality of care for the different abnormalities identify areas of risk due to environmental or other exposure to fetus, as well as assisting in the identification of care disparities. The original codes for maternal care for CNS malformations were deleted and replaced with an expansion in the O35.0. You can see that the codes are very specific as to the type of anomaly, and all of these codes have 7 characters to identify the affected fetus. Similarly, the original codes for maternal care for suspected chromosomal anomaly at O35.1X were replaced with several codes to identify the specific chromosomal anomalies such as trisomy 13, 18, 21. New subcategories were added to capture fetal anomalies of organ systems as well as those for musculoskeletal conditions specific to face, upper limb, lower arm, and trunk. 2 new maternal care related guidelines are added as shown here. And new codes have been added at P28.3 and P28.4 to differentiate between the different types of apnea. As you can see, there are unique codes for central, obstructive, and mixed sleep apnea. Central apnea is defined as sensation of breathing effort, while obstructive apnea is when there is an airflow obstruction, usually at the pharyngeal level. Mixed apnea is a combination of both central and obstructive apnea. Note, apnea of prematurity is classified at P28.49, and apnea of prematurity is a developmental disorder caused by immaturity of neurologic and/or mechanical function of the respiratory system. Another apnea-related change occurred in the Z code chapter. A code was added to identify encounters for when patients are seen due to an apnea alarm or bradycardia alarm or malfunction of home cardiorespiratory monitor, and there is no associated findings. The new code Z72.823 was created to capture the risk of apnea due to neurological injury from smothering or suffocation of the newborn infant that shares sleeping arrangements with an adult, also known as co-sleeping. The new codes add more specificity to the type of atrial and atrioventricular septal defects. Prior to these codes, Q21.1 classified many different types of septal defects. Expanding the codes provides more concise classification to assist researchers and surveillance staff in analyzing and understanding the reported information. P10 hamartoma tumor syndrome, or PHTS, is a rare syndrome caused by the P10 tumor suppressor gene. PHTS has a variety of manifestations, such as benign hamartomas, macrocephaly, autism spectrum disorder, and an increased risk of malignancy. These patients present for the first time to a wide variety of clinicians due to the diverse manifestations. Von Hippel-Lindau syndrome also was previously captured in the broad code Q85.8, and a unique code at Q85.83 was created to help identify the true incidences of VHL. For 2023, new codes have been added in all of the S06 subcategories using 6-character A to identify the intracranial injury with loss of conscious status unknown. Previously, the default for intracranial injuries was to use the 6-character that represented with loss of consciousness of unspecified duration. This implied the patient had an LOC, which may not be the situation. The default no longer assumes the patient did have a loss of consciousness, but rather that the LOC status is not stated. Another change in the S06 codes adds an inclusion note to classify brief loss of consciousness associated with intracranial injuries in this category. When the period of the LOC is documented as brief, coders will now assign the appropriate S06 code for with LOC of 30 minutes or less. ICD-10-CM has codes for primary blast injury for GI sites, lungs, fallopian tubes, and thoracic trachea, but not the brain. New codes have been added to identify primary blast injury of the brain. An explosion generates a blast wave that travels faster than sound and creates a surge of high pressure followed by a vacuum. The primary blast-brain interaction includes both the passage of the blast wave through the skull and the energy transfer of the blast wave compressing the torso that sends damaging energy pulses into the brain. Patients do not necessarily have a transit LOC or C-stars. There are injuries related to blast-induced neurotrauma such as cerebral edema, blood-brain barrier dysfunction, and cerebral vasospasm, which are different from other types of traumatic brain injury. There are many occupations such as military service members, law enforcement, miners, and so on that are exposed to blast overpressure, which is the underlying reason to facilitate these codes for research into the specific type of injury. This slide illustrates examples of these subcategory changes. A new subcategory was added to further specify methamphetamine poisoning, adverse effects, and underdosing from the broader grouping of amphetamines at T43.62. And now it is time for our second poll. Jordan, can you please review?
Yes. All right. So the discharge summary is the 26-year-old female was admitted following an MVA who was evaluated for a concussion. Her discharge diagnosis is concussion. So I am going to launch a poll and you can guess the answer. So what codes are assigned for the admission? S06.0x0A, concussion without loss of consciousness. B, S06.0x1A, concussion with loss of consciousness of 30 minutes or less. And C, S06.0xAA, concussion with loss of consciousness, status unknown. And D, S06.0x9A, concussion with loss of consciousness of unspecified duration. So we'll wait a few more seconds and then I'll close it out. Okay, thanks everyone. So it looks like everyone kind of chose C.
That is correct. The documentation did not identify a loss of conscious, and now the default status is unknown instead of unspecified duration. And we'll continue on reviewing some of the other changes. New codes were added throughout the motorcycle rider transport injury external cause codes. The purpose of these new codes is to differentiate electric bicycles from other forms of motorcycles such as mopeds, motor scooters. There's a growing use of electric or e-bikes around the world, and in order to study injuries related to e-bike use, separate codes have been added. A new code at W23.2 was added to subcategory W23 to identify a moving and stationary object. And now looking at the social determinants of health, or SDOH, it continues to be an area of development, which we are going to review on the next few slides. Starting with transportation insecurity, this code includes a variety of transportation issues, such as being able to afford transportation, access issues such as no access to transportation or long transportation times. A new code for financial insecurity, which includes burdensome debt, bankruptcy, money problems, unable to make ends meet, was created. Material hardship includes things like not being able to obtain basic needs like utilities, clothing, adequate childcare. Notice these codes can be used with other codes to more fully describe the social situation of the patient. And a related code for specific socioeconomic risk factor counseling at Z71.88 was created. This code identifies specific counseling to represent efforts of assessing and patient-centered goal setting to address those risks. Additional new codes have been incorporated to distinguish various or other types of patient non-compliance, such as with their diet or other medical treatment. Codes are available to capture whether this is non-compliance due to financial hardship or other specified reasons. Several new codes were added to address caregiver non-compliance with the dietary regime, as well as with renal dialysis or other medical treatments. Caregivers may also underdose the patient's medication, such as in the cases of a child, elderly, or people with disabilities. The codes differentiate from intentional underdosing and whether that intentional is due to financial hardship or another reason versus unintentional underdosing. For the underdosing codes, there is an instruction to code first the underdosing of the medication. Related to underdosing, the coding guideline for underdosing clarified that there need not be a change to the patient's condition to assign the underdosing code from T36 to T50. The documentation of taking less of a medication than is prescribed or discontinuing the prescribed medication is sufficient for the code assignment. And the guideline has been updated to provide additional clarity on assignment of SDOH codes. And here, as you can see, describing the problems or risk factor to social determinants should be assigned when the information is documented. You may assign as many codes as necessary, and that the code should be assigned only when the documentation specifies the patient has an associated problem, such as the example here, where Z60.2, problems living alone, would not be assigned for every individual living alone. And there are current clinical recommendations for transitional counseling as part of routine primary and special care for youth and young adults with and without special health care needs between the ages of 14 to 25. The new code Z7187 assists in identifying these counseling sessions. And if a patient has a specific health condition, it should also be coded as a secondary code, such as a congenital anomaly. Some medications also carry long-term risks for patients' health, and so there are a limited number codes in Z79 to capture these specific drugs. There have been 14 new codes added to add specificity related to the high-risk medication. And several new codes were added in the personal history of corrected conditions to capture a variety of conditions that continue to cause morbidity throughout a person's lifetime. The conditions are typically corrected in childhood, but the patient may continue to require monitoring or treatment, whether it's medical or therapeutic, for these other conditions. And now I would like to turn the presentation over to Dr. Julie Glasgow to review IMO calculator changes related to ICD-10-CM changes.
All right, thank you so much, June. Yes, I'll be going over the modifiers, also known as qualifiers. So those of you who are IMO customers, you're probably familiar with these. They are the prompts that IMO provides for many of our problem lexicals, and their intent is to supply help getting to a specific ICD-10 code. Go ahead and go to the next slide. So this is IMO, as usual, striving to bridge the needs of the clinicians documenting care and the need to code successfully for billing. So as you know, this year, there were a lot of ICD-10 code changes. They affected a lot of our lexical starting points, some of which are listed here. These are a lot of the more substantial ones. I'm not going to read them out, but note that there have been a lot of code changes this year that affected multiple starting points. Loss of consciousness status, that unknown value, that was a big one, the dementia details. I'll remind you that when we say calculator, we are talking about the user interface that presents the detailed prompts to you. It's going to look very different in different applications. The content itself is the same, and we will be showing an example interface in these little screenshots. So next slide. First one I'll show is anemia. If you've used our anemia calculator at all, you know it's a really big area. This is just an excerpt of it. So we've added a whole new group to call out those new hemolytic uremic syndrome subtype codes that were added this year. Next slide. Aortic aneurysm, here are all the more detailed locations in the aorta where the aneurysms might occur. And I'll mention that dissection of aorta also has more details added. They're only the thoracic locations, of course, because that is the most common location for the dissections. Next slide. Cardiac arrhythmias, more detailed types of ventricular arrhythmias have their own code, and here they are. Next slide. So that coronary artery disease, there is refractory angina. Our chest pain calculator also has this new detail added. Next slide. Yeah, dementia. Very impactful change here. Severity plus a wider range of behavioral and psychological symptoms. This is just an example, multi-infarct dementia, but this will be quite impactful for users trying to get to a specific ICD-10 code. Next slide. We have built in the new code for ME/CFS. No longer does it map to the unspecified chronic fatigue code, which is very helpful. This other post-infection and related fatigue syndrome should also be useful. And then, of course, the old post-viral fatigue syndrome code is still in this calculator for your use. Next slide. Those intracranial injuries, this new value occurs in a lot of places in the entire set of diagnoses. This is just an example, epidural hemorrhage. As June illustrated, if nothing is documented about loss of consciousness, then the new default is unknown LOC status. But a clinician could document that the patient presented in a conscious state, but the clinicians were unable to determine whether there had been loss of consciousness due to the injury. And this would also be the appropriate code in that situation. Next slide. This is the last one I'll show you, sleep apnea. We previously had the primary sleep apnea of newborn choice in this calculator, so now we have added a whole new group for those new primary sleep apnea of newborn codes. And that is it from me. Go on to the next slide. If you have questions on any of this content, you can add it to the question chat. And yeah, back over to you, Jordan.
All right, thanks June and Julie for an awesome presentation. So at this time, we'll be kicking off our live Q&A. So any questions you have for our presenters, please ask them in the questions section. They're experts, so just know that. But please excuse any brief silence while we review. I know a question came in about the continuing ed credits. So I will give you a certificate of attendance after this webinar, and you can turn them into your governing body. June, someone is asking if you could show the atherosclerosis slide.
Yes, hang on one.
Modifiers.
Yes, we'll go back to that. Hold on.
And yes, he will get a copy of the slideshows and the recording as well. So one question came in about, I want to understand why there are unspecified laterality diagnosis codes available. Is there a way to hibernate those records without a lot of maintenance for each new IMO file import? We have providers using the unspecified and creates many claims denial.
So this is June, and I will start with that. And it is, you know, there are times and that the laterality, we have to provide the broad depth of content that is available for those situations. I understand the concern around that. in relationship to the downstream revenue cycle processes. However, since they are part of the system and they are, we have to have the terminology available along those lines for that aspect. And, you know, unspecified codes, there are times, as probably many folks on this webinar know, that they're very appropriate because it's unspecified through the lens of ICD-10-CM. So in that instance, that is why, and I don't know, Dr. Glasgow, if you have anything to add to that, but as they are, you know, there are times that may not be known, and it is part of the system that we have the content available.
Yeah, that is true. There are a lot of clinical situations in which the laterality isn't known yet, and you know, plus CMS does explicitly instruct folks to make available all the codes because of that reason. The classic example would be like an incoming transition of care. The patient has some sort of condition that is in, you know, one of their legs, but the information isn't complete yet. They're not sure which side it is, but they do know, you know, that it's a laceration or whatever. So it's good to get a coded diagnosis on the patient's record as early as possible in that workflow. So that is one of the situations when it's useful to have an unspecified laterality code. Our thinking lately has been that it will be useful to have a way to indicate to providers themselves when a diagnosis lexical is associated with an unspecified ICD-10-CM code. And if they're trained to realize that that can be very impactful, then they will know that they have to add more detail when they're recording their own diagnosis. To us, that's a potentially very fruitful route to go, and a lot of the EHR vendors are supporting such a visual indicator to the providers. Hope this was helpful.
Yeah, I think it was. So we are at time. I think that's kind of it for questions. And I'm going through making sure that we answered everything. But we're going to go ahead and close out. I hope you found the information in today's webinar useful. Be on the lookout for the recording of the webinar, the slides, the certificate of attendance. If you have any questions regarding technical support or even content questions, please contact customer support at imohealth.com. Or if you have any information regarding IMO or our solutions, please contact sales at imohealth.com. Thanks so much for attending, and I hope you have a great rest of your day.